Hi everyone, I just wanted to go ahead and do the review for our exam coming up on Tuesday. There is about, I think, 10 select all that apply questions, and there, I believe, is about 45 questions, something like that. Okay, I can't remember off the top of my head. Okay, it does cover renal, endocrine, and then the oncology and end of life. Okay, so I'm going to go ahead and just kind of go through the study guide. All right, so the first thing we're going to do is talk about renal. So when we talked about renal, we were talking about an acute kidney injury. So this is not chronic renal failure. That would be a different pathophysiology. Acute kidney injury is when you have another problem that has occurred that is causing damage to the kidneys. And there's 3 different types of acute kidney injury. The most common type that we see is pre-renal, okay? Pre-renal means there's some impaired blood flow coming to the kidney. So that could be related to decreased cardiac output from cardiogenic shock. It could be hypovolemic shock. It could be septic shock. It could be related to bleeding. Okay, could be related to some impaired vascular flow, like an aneurysm. All right, so pre-renal means that there's impaired blood flow going to the kidneys, so it's not getting enough oxygenation to function correctly. Intrarenal means there's a problem inside the nephrons, inside the tubules itself. Intrarenal is a lot less common. And this one we see due to toxins. So it could be medications like antifungal medications, antibiotics. It could be related to an overdose of a medication, ischemia as well, from maybe a burn or something like that. The other thing that causes a lot of intrarenal problem is chemotherapy. Okay, so again, chemotherapy is toxic to all tissues, not just the cancer tissue. And so what happens is you develop acute tubular necrosis. So we talked about this a lot in burns. So remember, in burns, your skin and your muscle gets burned. And when your muscle burns, it turns into myoglobin. And that myoglobin, those are large molecules, and they get stuck in the tubules and they cause acute tubular necrosis. So intrarenal is very common in burns, okay? But pre-renal is your most common type of acute kidney injury. And then post-renal, this is an obstructed flow, okay? So you've got your renal pelvis right here. You've got your ureter coming down to your bladder. So somewhere from your renal pelvis down into your ureters, there's some kind of an obstruction. Whether that's the prostate, could be kidney stones, it could be a tumor. Something is blocking the urine flow out. Okay, so 3 types of acute kidney injury. Pre-renal, most common. It's related to shock and loss of blood and impaired blood flow to the kidneys. Intrarenal, you see this with burn patients and oncology patients. It is an damage to the nephrons inside the kidney, causing acute tubular necrosis. And then post-renal, you most commonly see it with prostate disease or renal stones, kidney stones, okay? And then I just kind of put in some information that you should know about your labs. So our gold standard to measure kidney function is our GFR, glomerular filtration rate. That tells us how well our kidneys are filtering. That is our gold standard. And what your glomerulus does is it filters out creatinine from your body. Okay, so that's the function of the glomerulus. So when we're looking at treating patients in acute kidney injury, how do we evaluate the effectiveness of our treatment? Well, we're going to look at our filtration rate, which is how much urine are we making? How much are we filtering out and creating for urine output? So our urine output needs to be 0.5 mLs per kilo per hour. Okay, so again, GFR is our gold standard. It filters out your creatinine, makes your urine. I look at my urine output to see if my treatment is effective, and I'm looking for 0.5 mLs per kilo per hour. Okay, so that's talking about acute kidney injury. There's different phases of acute kidney injury that your patient will go through as well. The first phase is that oliguric phase, okay? So your GFR is decreased. So if my glomerular filtration rate is decreased, my urine output is going to be decreased because I'm not filtering, I'm not making any urine, okay? So if I'm not filtering out my creatinine, I'm going to have increased BUN and creatinine. I'm going to have increased potassium. So remember, if I have high potassium, I will have high T waves. Okay, so I might see some EKG changes. I might also see some drop in my sodium level because, again, I'm not putting out any urine. Okay, so hyponatremia, low sodium can cause cerebral swelling, peripheral edema. Okay, so just kind of watch that for those patients. So oliguric, not making urine, not filtering creatinine. Then the second phase of acute kidney injuries, they go through an autodiuresis or a diuretic phase where they start putting out a lot of urine, so up to 5 liters a day. So again, they can be hyponatremic and hypokalemic, and they can go into a dehydration state. So you really want to be monitoring their I's and O's. And then the recovery phase of acute kidney injury can take up to a year for the kidneys to stabilize, depending on how badly they were damaged from what occurred. So this is that little lady again. So here it is again, just looking at the signs and symptoms of acute kidney injury, looking at the different phases. Oliguric, decreased glomerular filtration rate, increased creatinine, decreased urine output, okay? Increased potassium, so you might see some EKG changes. So again, if a person has acute kidney injury, and this is new, you know they're going to be in the oliguric phase, so one of the priorities is putting them on a heart monitor to make sure that they're not having any arrhythmias, okay? And then the diuretic phase, they're going to be dumping urine up to 3 to 5 liters a day. So they're going to be dehydrated, hypokalemic, hypovolemic, hypotensive, okay, hyponatremia, okay, so that's in the diuretic phase. And then the recovery phase, this is when things are starting to normalize. So again, this just kind of goes through the phases, again, talks about the difference in the urine output and the glomerular filtration rate. So again, it's just another study tip there. All right. So what are our goals for caring for patients with acute kidney injury? We want to eliminate the cause. So again, the cause is going to be either pre-renal, intrarenal, or post-renal. So if it's an intrarenal problem and I have decreased cardiac output and decreased blood flow because of shock, I need to treat the shock, whether that's giving fluids, starting them on vasopressors, vasoconstrictors, positive inotropes, whatever it may be. That's how I would treat pre-renal cause. Intrarenal cause, if there is maybe a burn patient and they have ATN because of the breakdown of the myoglobin, I want to wash all that myoglobin out. So that's why we give them large amounts of fluid resuscitation, okay? And then if it's a post-renal, maybe it's a prostate problem, you could do a prostatectomy. If it's a renal stone issue, kidney stones, then again, you can do a lithotripsy or some other things to try to eliminate an obstruction, okay? You want to manage their signs and symptoms. So signs and symptoms could be increased T waves, cardiac abnormalities, edema. It could be hyponatremia. Okay, so they could be hypotensive. So again, whatever signs and symptoms are displaying, you would want to treat those. And then prevent complications. So if the potassium is becoming very high, you can treat them with IV insulin. So that would be regular insulin and sodium bicarb, or you could try calcium gluconate. If you're giving K-exolate PO, make sure you're checking their bowel sounds before you give them anything PO. All right. And then we talked a little bit about dialysis and doing the 24-hour dialysis, which is called CRRT, continuous renal replacement therapy. So the indications for that is if you're having a patient with acute kidney injury and they're having significant organ involvement. They have a change in their mental status. They have fluid developing around their heart. They have fluid in their lungs. They've developed a tamponade, or they're hemodynamically unstable. Okay, so those would be indications for doing CRRT, continuous renal replacement therapy. So these are just some interventions for patients with acute renal failure. So again, this is an acute issue. This is not chronic. So you'd want to closely monitor your I's and O's. Okay, monitor your labs. So again, that would be your BUN, your creatinine, your potassium, and your sodium. Okay. Hyperkalemia, really watch for hyperkalemia. It's very common that they would have potassiums above 5. And then you want to look for signs and symptoms of hyperkalemia. Really watch that EKG rhythm. So again, patients with acute kidney injury, one of your priorities is to place them on a cardiac monitor because you know they're going to be hyperkalemic. And you want to make sure that you're preventing any complications like an arrhythmia. Okay. And then making sure you're doing daily weights. And then assessing for any signs of fluid overload or heart failure. Okay. Renal diet, you want to make sure that they're getting adequate calorie intake. It should mainly be carbohydrates and fats. You want to limit the protein, restrict their sodium. It again needs to be carbohydrates and fats. Okay. If you have a patient that is getting dialysis, you always want to make sure that you're checking their blood pressure after dialysis. And if they have any complaints of anything after dialysis is completed, you always want to go ahead and check their blood pressure again. Okay. If they have an AV fistula, that's an arteriovenous fistula where they put the artery and the vein together so that they can do dialysis through their arm instead of doing it through a IV catheter in their neck. Okay, so if you have an AV fistula, you want to make sure that you're listening for a bruit with your stethoscope, palpating a thrill to the site, and then if they have any changes in circulation to that extremity, you immediately notify the provider. Okay. So that's kind of it with dialysis. So again, circulation changes, notify the provider. You always want to be checking their blood pressure. Okay, so those are the two key takeaways from that one. And then we talked a little bit about kidney transplant. So advantages over dialysis is it is more cost effective. You can have reverse in pathological changes. It eliminates the dependence on dialysis. So you can kind of get back to your regular life. Okay. It does take a lot of emotional and physical support because they're going to need immunosuppressants therapy after they've had their transplant. Okay. They need to keep taking those. So, if you did have a transplant, there is a possibility that you would reject the organ, and there's 3 different types of rejection that we see. Hyperacute is immediately, hours, minutes to hours after transplant. So this can occur even in the OR. As soon as they release the clamps and let blood flow through the new kidney, they can have an automatic rejection of the organ. So that would be hyperacute. Remember, it can occur in the OR minutes to hours after transplant. An acute rejection, this one can occur days to months after transplant. And then a chronic rejection, this would occur over a longer period of time, okay? And a chronic rejection is irreversible. So when we're looking at medications for patients that have had transplants, we already kind of talked about immunosuppressants. The other medication that they take is corticosteroids. So when you're thinking about corticosteroids, think about all the other problems that kind of come with that, such as decreased ability to fight off infection, increased glucoses. It also can contribute to peptic ulcer disease. The big one that we get concerned about is necrosis of the hips, knees, and other joints. So corticosteroids leads to osteoporosis, and it can break down your hips, knees, and joints. Okay, so that's a key one to remember. All right, so that's pretty much it for renal. So again, we talked about acute kidney injury being pre-renal, intrarenal, or post-renal. We talked about the importance of glomerular filtration rate, filtering out creatinine, making urine output. We assess urine output to assess the effectiveness of our treatment, and we're looking at 0.5 mLs per kilo for hour per patient. And then we talked about looking at the different phases of acute kidney injury. You have your oliguric, which is where you stop making urine. Okay, you have your diuretic phase where you start dumping out a lot of urine, and then you have your recovery phase. Okay, and then we kind of talked about dialysis a little bit, so making sure that you keep checking that blood pressure, and then checking the site of your dialysis catheter for infection or your AV fistula for circulation. And then we talked about transplants and rejection. So you can have a hyperacute rejection, which occurs within minutes, an acute rejection, which occurs days to months, or a chronic rejection, which takes a longer period of time and is irreversible. Some of the medications patients have to take for a transplant are immunosuppressants and corticosteroids. The big thing that we're concerned about is osteoporosis and necrosis of hips, knees, and joints. So if a patient was on corticosteroids and they started complaining of pain to their hips and their knees, that might be something you would be concerned about related to that medication. All right. So that's it for renal. So let's have a look at endocrine, okay? And I didn't put them in any particular order. I did find my picture of the circus elephant though, okay? So I started off looking at our pituitary gland and looking at antidiuretic hormone, ADH, okay? And there's two phenomenons that we look at with ADH. There's DI, which is diabetes insipidus, and then there's SIADH, which is the syndrome of inappropriate antidiuretic hormone. So let's look at diabetes insipidus first, okay? DI means you're dry inside. DI, dry inside. You are dumping fluid, peeing like a circus elephant. They dump tons of urine. Their internal chemistry is very dry, so they have dry and high labs. They have a high serum osmolality, okay? But the osmolality of their urine is low. It's low like water, okay? So diabetes insipidus, so just remember all these Ds, okay? So dry inside, peeing like a circus elephant. They're dumping urine, they're dry, high dry labs, so they'll have a high serum osmolality, but because they're dumping pee like a circus elephant, they have a low urine osmolality, or urine specific gravity is what you're looking for. Same thing. So here's our little guy from our video. He is dry. Okay, and you see he's standing in this big puddle of urine. Okay, so remember all your D's. He's diuresing, high urine output. His urine is diluted. So again, low specific gravity. Okay, so low osmolality for the urine, low specific gravity. It's like water coming out. He'll have high dry labs, high serum osmolality, high sodium, okay? He's going to be very thirsty. He's going to be dehydrated, decreased blood pressure. And the medication that we treat it is desmopressin. So again, remember, high and dry is all your Ds, okay? And then the opposite of that is syndrome of inappropriate antidiuretic hormone, okay? So in this one, we stop urinating. So SIADH, stop urinating, okay? We become swollen, soaked inside, low liquidy labs, low sodium, low serum osmolality. But again, we've stopped urinating, so we're going to have a high urine specific gravity. Oh my goodness. Sticky, stinky urine. Okay, remember all your S's are for SIADH. Okay, so here's our SIADH guy. All right. So looking at them side by side, DI is going to have high urine output. Okay, so high is I, DI is high. SIADH, stop urinating. Okay, they're not going to have urine. They're going to have high and dry labs, so they're going to have high sodium and they're going to be dehydrated. In SIADH, they're going to be low liquidy labs, so they're going to be low sodium, overhydrated. Okay, so again, there's a couple of different things you can kind of compare them side by side. Okay, again, if you want to watch those videos again, those links are on your weekly outline that were posted in the announcements, and they're also in the modules in the files. So if you're looking for, it would be like week 11, so module 11. If you go in the file for module 11, that class outline for that day will be in that file with the video link in there. Okay, so you shouldn't have a problem finding it. All right, so we'll talk about adrenal gland. So our adrenal glands secretes a couple of hormones. So corticosteroids are sex hormones and glucocorticosteroids. Okay, so it controls our sugar, our sodium, and our sex drive. All right, so when we're looking at Addison's disease is low steroids, low. She looks so sad and so low. She has a bronze pigmentation to her skin, okay? She's got some GI disturbances. She's going to be hypoglycemic because this is low, so she's going to be hypo. She's going to have hypotension, and she's going to have weight loss, okay? So this is Addison's disease, okay? Compared to Cushing's, this is Cushy Carl. Cushy Carl is hyperglycemic. He's got too much. He develops a moon face, weight gain. He develops that hirsutism, okay? So that's what Carl develops. He has fat deposits. He develops the hump, Cushing's hump on his back. He's got it right there. You can't really see it on Cushy Carl here. But this is Cushing's, okay? So again, looking at them side by side, Addison's is low steroids, Cushing's is high steroids, okay? So Addison's, you're gonna add the pigmentation. They're gonna be more of a bronze toned. They're gonna have decreased weight. They're gonna have decreased blood pressure, hair loss, decreased blood sugars. So everything's going to be low, hypoglycemia, hypotension, okay? And then they're going to have hyponatremia as well, so low sodium levels. As opposed to Carl over here, Cushing Carl, he's hyper, okay? So he's going to be hypertensive. He's going to be hyperglycemic. He's going to have a round moon face, okay? He's going to have hypergrowth of his hair, that hirsutism, okay? So that is hyper. So here's another one kind of side by side. So the treatment, again, is you're looking at adding steroids, Addison's, if they're low. You would want to start them on steroids, but they can't stop taking them too quickly. They have to wean off of them, okay? And then Cushing's, you would do surgery to remove the tumor, remove whatever is going on, and then you would give them steroid replacements once you've removed that adrenal gland or tumor, okay? All right, so let's talk about thyroid is next. So thyroid, so when we're looking at thyroid function, there's again a couple of labs that we look at. TSH is your thyroid stimulating hormone. This is the gold standard that you're going to look at, and it indicates the function of the thyroid gland, okay? The other two, free T3 and T4, they're indicating how much thyroid hormone is in the blood circulating around, but it doesn't tell you how the organ is functioning. It just tells you if you have a lot of thyroid or a little bit of thyroid, okay? So the TSH is the one that we really look at. And then there's two different types. Again, you have your hyperthyroidism, okay? So everything, your metabolic rate is hyperactive. So you're sweaty, you're hot, you have weight loss, muscle wasting. You can have those bulging eyes, so the exophthalmos eyes, all these big words, and large thyroid flushing from the high blood pressure, those kinds of things. And when you have an emergent situation with hyperthyroidism, this is when you develop thyroid storm. Okay, so hyper is that storm. You're in a hyper metabolic state. And then we're looking at hypo. Hypo is a low, slow metabolic state. So you have hair loss, dry skin, you're lethargic, you have weight gain. They can be bradycardic, have trouble maintaining their temperature. They can have mental status changes, okay? So if hypothyroid becomes a problem, then you can go into a myxedema coma. So think hypo and coma, they both have an O in there. Okay, I don't know if that helps or not, but anyway, because I guess thyroid storm does too, but whatever. So anyway, hypo is that coma, okay? Hyper is that storm, okay? So maybe that's a better way to think about it. So let's kind of look at them side by side. So again, hyper, this is Tigger, right? He's jumping around. Look at me, jump, 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 jump. They're hyperactive. They have a hyper metabolism. They're super skinny. They can eat all the donuts they want, and they never gain a pound. It's terrible. So because they have hyperthyroidism, they're going to have high T3 and high T4, okay? A lot of times, it can be an autoimmune disorder called Graves' disease. So again, you may have seen that as well. And again, they have those large exophthalmos eyes. They can have a goiter around their throat area, high blood pressure, high heart rate, high. Everything's high and hot, okay? As opposed to Eeyore over here, poor Eeyore, he was always my favorite. He's so sad and so slow because he's hypo, okay? So a lot of times you see this with Hashimoto's disease. So in comparison, your T3 and T4 are going to be low. So this patient needs some thyroxine, right? So everything is going to be low energy. So again, think of Eeyore as being low, slow, poor Eeyore, okay? And then your hyperthyroid over here is your Tigger, who's just excited about everything. So hopefully that will help with thyroid. All right, so let's look at parathyroid. So parathyroid, these are those 4 little areas that sit on your thyroid, okay? And with parathyroid, we're really looking at calcium, okay? So your parathyroid hormone equals calcium. So if it's hypoparathyroidism, I have low parathyroid hormone, I have low calcium. If it's hyper, then I have high calcium. So your signs and symptoms are basically hypocalcemia and hypercalcemia. Okay, so let's look at low, seeing as though this one is up there first. So hypocalcemia, so you can use the acronym CATS, convulsions, arrhythmias, tetany, spasms, and stridor. So a lot of times this is when you're doing that Chavox sign or Trousseau's sign. I think I have a picture of that next. Looking for pins and needles or paresthesia to the fingertips, prolonged QT intervals, okay? So that's where your arrhythmia comes into play. So if you remember, prolonged QT intervals put you at risk for VTach torsades, okay? So parathyroid, it's all about the calcium. So low parathyroid is low calcium. High parathyroid is high calcium. So this is just some nursing management of calcium. So again, here is that Chavox sign and Trousseau's sign. Usually we use a blood pressure. We don't like squeeze their arm. Usually we just use a blood pressure machine. So, all right. And then hyperparathyroid or hypercalcemia. So what happens is that parathyroid hormone, what it does is it moves calcium out of the normal storage areas in the body, which is our bones. So a lot of times if you have high calcium, you're going to develop kidney stones, fractured bones, and constipation. So it was stones, groans, and moans. So kidney stones, groans from fractured bones, and moans from constipation. Okay, so those are the ones to remember for hypercalcemia, hyperparathyroid. All right. And then we talked about DKA and HHNS. So DKA, you see this in type 1 diabetics. It's a lack of insulin. They just don't have it. Okay. Blood sugars are typically around 500s, could be as much as 600s, but usually not much higher than that. They have ketosis. Okay. DKA is diabetic ketoacidosis. So they have ketosis and they have acidosis. It's in the name, K and A. And they are very dehydrated. Okay, so let's look at how we treat those patients. Oops. Here we go. So you want to rehydrate your patient. That is number one. And we use a crystalloid, normal saline. Okay, so typically you're running normal saline at about 200 an hour until their blood sugars are less than 200. Okay, it's typically what we do. Once you've got your fluids going, that's when you're going to start your insulin. You only give regular insulin IV. Okay. Typically we give a bolus dose and then we start a continuous infusion, and you're going to check your blood sugars every hour. At the same time as we're infusing our insulin, we're going to check our potassium and replace our potassium per our protocol. Even if your potassium is on the normal low side, you still want to replace it, because as your blood sugars move, your potassium is going to move with it in and out of the cells. Okay. So once our blood sugar is 200 or less, now we're going to change our IV fluids and we're going to add some dextrose to it. Okay, so D5NS. And we're going to transition from IV insulin to sub-Q insulin. The other thing we look at is our anion gap. We're looking to see if we are still in ketosis. If our anion gap is normal, or what we would call closed, it means we're no more in ketosis. We're now back into a normal metabolic state where we make water and glucose. Okay. And so that's when we can change back to sub-Q insulin. All right. So this is just kind of signs and symptoms of DKA. So again, here's your little turtle. Hi. So you need hydration, insulin, and electrolytes. Hi for DKA. Okay. And then I did put on here some insulins. It's not on the test and we didn't really talk about it, but it's just a really nice graphic reminder for the NCLEX exam, because there will be questions on insulin, trust me. Your long-acting, your Lantus, it could be your Detamir, your Levemir, something like that. This is your basal dose. Basal means it's continuous for over 24 hours, okay? Your basal dose onset is 70 minutes. And then you have your longer acting insulin, your NPH. This is your one that's cloudy, right? And this one, 60 to 120 minutes. But the peak is in 6 to 14 hours. You do need to know the peaks as well, okay? Again, this is not on our test, but it will be on the NCLEX, trust me. And then this is your regular insulin and then your Lispro. So again, this was just a extra little thing just to kind of help you for the future. All right. So we talked about DKA being type 1. HHNS is type 2 diabetes, and the blood sugars are a lot higher, okay? 600s to 800s. They can be in the thousands. They're profoundly dehydrated. However, it's in the name, HHNKS, non-ketotic. So they don't have ketones, they're not acidotic, and they have a normal pH, okay? As compared to DKA, it's type 1, where they're in ketosis and they're acidotic, okay? HHNS is not, okay? They are normal, all right? But the treatment is the same. You're still going to replace their fluids. And a lot of times, because they're not acidotic, as soon as I give them fluids, it's going to dilute their blood sugars. And it's probably going to decrease their glucose levels just by rehydrating them. Okay, so again, they're profoundly dehydrated. So if they're profoundly dehydrated, their serum osmolality is going to be high. If I rehydrate them and thin out their blood sugars are going to start to come down. So that's really nice. The other thing you want to do again is correct any electrolyte imbalances and then give insulin based on what your sugars are. And there'll be a physician order for that. So again, when you were looking at them side by side, DKA is type 1, HSS is type 2. DKA sugars will be greater than 200 up to about 500 or 600. HSS, they're going to be greater than 600, more in the 800s to 1,000 range, okay? Because DKA, you have ketones, you develop that fruity breath, and you become acidotic and develop that Kussmaul breathing. We don't go into ketosis with HSS, okay? So there's no fruity smell, no ketones, no acidosis. Your pH is going to be normal, okay? Both of them, you are dehydrated, but HSS, you're profoundly dehydrated, okay? And then again, the treatments are the same. All right, so that's it for endocrine. So oncology. So we did talk about skin cancer, and there's different types of skin cancers that you could see. Keratosis, basal cell carcinoma. Basal cell carcinoma, this is our most common skin cancer that we see, okay? Squamous cell, and then dysplastic nevi. So risk factors are people that are fair-haired and fair-skinned, and then chronic exposure to sun. And so just remember, this is modifiable. These are not. Okay. Other thing with skin cancer is looking at your family history as well, and that would be non-modifiable. And then we kind of use the ABCDE rule to kind of assess skin changes and look at differences. So we're going to look for the symmetry of the mole. We're going to look for border irregularity, color changes, and we're going to look at the diameter, okay? And then we're going to look for any changes in appearance. All right, so that we use for the assessment of our moles. So ABCDE, symmetry, border irregularity, color change, the diameter of the skin mole itself, and then looking at changes in appearance. And then we kind of talked about lymphomas, and we kind of focused on two types of lymphomas. One is Hodgkin's lymphoma. The other one is non-Hodgkin's lymphoma. So if we're looking at them side by side, Hodgkin's lymphoma, this is the one where you have your B symptoms. Those B symptoms are profuse night sweats, fever, weight loss. It's typically related to Epstein-Barr virus, and you have Reed-Sternberg cells. The outcomes are very good and very favorable for Hodgkin's lymphoma. They use a combination chemotherapy and then radiation. As compared to non-Hodgkin's lymphoma, you're looking at diffuse B cells and T cells. It's typically related to some kind of an autoimmune disorder, and it is diffuse. So it's based upon, the signs and symptoms are going to be based upon what organs it's affecting, okay? You're going to use a combination of chemotherapy and radiation, and the prognosis is not as good for recovery. Liver cancer we talked about really quickly as well. So again, a lot of times that's related to hepatitis B, hepatitis C, or liver cirrhosis. So you'll see some enlarged liver and enlarged spleen, portal hypertension, jaundice, edema, ascites. And then the treatment for liver cancer is a partial removal of the liver, and that is your best chance for a cure. You can also have a liver transplant, or if you have a localized tumor, they can do radiofrequency ablation where they put electrical activity to the site itself. They can deliver chemotherapy to the tumor itself, or they can do alcohol injections, which kills the tumor cells. Prognosis for liver cancer, however, is poor, and it can develop quite rapidly. Okay, so the big thing is to provide supportive care and help control pain. So anytime you do have a patient with cancer, you always want to take into consideration their psychosocial care as well, looking at anxiety, their body image, and then their grieving. So that kind of takes us to our last topic of end-of-life care. So we talked about the difference between palliative care and hospice care. So palliative care begins at the time you're diagnosed, and it extends throughout the time that you're receiving treatment up to the time that you are in the dying process and going through the death and dying process. Whereas hospice begins after treatment has been completed or stopped. Okay, so that is the difference between those two. Goals of end-of-life care, you really want to improve the quality of life for your patient, not the quantity. You want to decrease healthcare costs, keep them home if you can, and alleviate the burden of care. So look at respite care, those kinds of things. And then these are some signs and symptoms of imminent death. So typically everything slows down, metabolism slows down, you're incontinent of urine and stool, you have irregular breathing patterns. You may have that death rattle where you're unable to clear secretions. You can have neurological changes, sensory changes, cardiovascular collapse. You become bradycardic, hypotensive. You get cyanotic and mottling. And then these are the stages of Kubler-Ross, stages of grief: denial, anger, bargaining, depression, and acceptance. So that is it for exam number 2. I'm going to stop recording.